Good morning, everyone. Mr. Chairman, thank you very much for the invitation. It's a great pleasure, obviously, to be here and see some of the old colleagues. In the next 10 minutes, we will try to cover first-time patellar dislocation and address some of the misconceptions around the management, including presenting a new risk factor scoring model that we developed, which helped to stratify the risk of recurrence as well as guiding the management plan. As we all know, acute lateral patellar dislocation is one of the most common injuries that we all see in our practice, including active, especially in active adolescents and young adults, with a peak age somewhere between the age of 10 and 17. And many of the published literature suggests an incidence somewhere between 30 and 40 cases per 100,000. No gender difference, as we know, for the primary dislocation. However, female patients, they tend to have much higher risk for recurrence, with the recurrence rate in general is around 30 to 50%, with most of these they occur in the first 18 months after the first time patellar dislocation. As we all know, the classic teaching has always emphasized the importance of conservative treatment as the main and perhaps the only treatment for first-time patellar dislocation, with indications for surgery, osteochondral fractures, or severe disruption to the medial patellar stabilizers. However, over the last 5 to 7 years, more studies have come out suggesting actually conservative treatment is not always the best for these patients, and it doesn't give the results that we may think. So Magnuson from the US back in 2017 followed a cohort of patients treated conservatively after first-time patellar dislocation over a 3 years period, and only found 26% of those patients managed to return to their previous activities, and most of them are citing the injured knee as the main reason why they couldn't go back. Other studies as well suggest the development or high risk of degenerative changes within the patellofemoral joint following non-operative treatment. Since 2014, few authors around the world started to come with predictive tools to suggest how we can tailor the decision-making process, considering the impact of each risk factor individually and in combination on the incidence of recurrence. However, most of these predictive tools, they do not suggest any specific treatment plan for these patients. The core principle is if recurrent instability and poor outcome could be predicted, then alternative treatment or early surgical stabilization after first-time patellar dislocation could be considered. These tools as well can predict the contralateral side instability and possible failure of surgical treatment. Based on our work since 2006 with patients with first-time patellar dislocation, we presented in 2018 our Warwick patellofemoral instability risk factors model. The difference in that model compared to other published tools is it not only stratifies the risk of recurrence, but it guides clinician to different lines of treatment depending on the underlying pathology, as we will see in the next few slides. So in essence, that model combines demographic risk factors, which are well known and well published, clinical risk factors, and that is basically the clinical signs that we see during examination. We found some of them are clinically relevant as risk factors. They can predict the recurrence and they can guide the treatment. And finally, the modified anatomical risk factors. Anatomical risk factors are well known and not new. They have been published since 1994 by Henry Dejoux and Walsh. However, in this model, we'll see that we modified them in a way which can guide the clinician on the treatment plan. As far as the demographic risk factors, being young, 16 or less, having a contralateral first-time dislocation, positive family history, being a female patient are all well-known demographic risk factors. However, how about the clinical risk factors? For us, we found 4 clinical signs are the most relevant. Positive G-tracking, whether unilateral or bilateral, and that is effectively an objective way to say this joint is unstable, this PFG is unstable. It's similar to positive pivot shift test in an ACL deficient knee. That's a pathognomonic of anterolateral instability. Positive patellar apprehension test is another important clinical risk factor. It reflects a decompensated patellofemoral joint from a neuromuscular point of view. Increased lateral translation at 30 degrees knee flexion beyond 10 millimeters with a soft end point is very much the same like positive Lachman test. It reflects an incompetent MPFL. And finally, increased what we call it dynamic TTG offset. This is a sign that we described in 2014, and we'll explain it more in the video in the next couple of slides. How about the anatomical risk factors? We refer to them as TAP, T for the track or the trochlea, and for us, it is only significant when it is severe trochlear dysplasia on the Dejoux classification B or D, and that is a bulky, deformed trochlea with a significant supratrochlear spur. The A for the alignment of the extensor mechanism in relation to the limb alignment. As Vicente explained elegantly in his previous talk, it's really, we don't pay much attention to the alignment of the extensor mechanism. For us, it is a combination of the TTG offset of 25 millimeters or more together with a patellar tilt, 20 degrees or more. It is a combination of them which we would, for us, means something has to be done around the tibial tubercle. Finally, the patella or the carriage on the track and a patella alta high riding patella with a Caton-Deschamps index, and we'll explain why we use the Caton-Deschamps of 1.4 or more. So according to when we combine these 3 risk factors together, which we extracted them from history, examination, radiological assessment, we stratify our patients into low, medium, high, or severe risk. With the first 2, whether it's a low or medium risk, they will still be treated conservatively following first-time patellar dislocation. The high risk group, they would have a restorative treatment in the form of MPFL reconstruction, and the severe risk, which is effectively like the high risk plus 1 or more abnormal anatomical risk factor, they will have reconstructive procedure, and that will be MPFL plus a bony procedure of some kind, depending on the bony pathology. It could be trochleoplasty in severe trochlear dysplasia, tibial tubercle distalization, mainly in cases of alta, or derotation osteotomy if we have a significantly malaligned system. So for the low risk, if a first-time patellar dislocation has 1 demographic risk factor, will be within the low risk group and will be treated conservatively. If they have 2 demographic risk factors or a single clinical risk factor, i.e. positive apprehension, positive G-tracking, increased lateral translation, they will still be a medium risk. If they have the same for 1 demographic risk and 1 clinical risk factor. Once patients have two clinical risk factors or two demographic risk factors plus one clinical risk factor, that will be classified as high risk and it would require MPFL reconstruction. Thank you. Okay, so let us start with the right knee only. Move the right knee. Okay, so that is positive G tracking. For us, that means objectively unstable patellofemoral joint. Just exactly the same like positive pivot shift in anterolateral instability of the knee. On the left side, we can see increased lateral patellar translation by 10 millimeters or more with a soft end point. That means an incompetent MPFL, exactly the same like a positive Lachman test in ACL examination. Back in 2014, we described this dynamic TTTG offset, and that is basically we started to see this sign, which is increased passive range of external tibial rotation in patients with generalized ligamentous hyperlaxity. And to us, that explained a subgroup of patients in whom we could see patellar, first-time patellar dislocation. You scan them, you examine them, and you scan them, and you don't have any significant underlying bony abnormality. Yet they dislocate, and typically their dislocation is in the early flexion over a fixed and externally rotated leg as they turn their body inwards. So when we have an increased dynamic TTTG offset, that is another clinical risk factor in these patients. So we'll just go through 3 cases where we applied that model. This is a 15-year-old boy with bilateral first-time dislocation. So he has 2 demographic risk factors, being young and bilateral. From clinical examination, this patient had 3 clinical risk factors: bilateral J tracking, positive apprehension, and generalized hyperlaxity, but mild dysplasia. So he's high risk. What we've done for the patient is a MPFL reconstruction. How can we isolated MPFL reconstruction, which eliminated his problem, eliminated the J tracking, and you can see the other side is still showing signs of J tracking. Second case, first-time patellar dislocation, 19-year-old male, so no demographic risk factors, however, has 4 clinical risk factors: bilateral J tracking, positive apprehension, increased lateral translation, and increased TTTG offset. What we've done on him is an MPFL reconstruction together with distalization osteotomy for following his first-time patellar dislocation. The last one is a 10-year-old boy with first-time dislocation, so 1 demographic risk factors, but had positive bilateral J tracking, positive apprehension, and increased lateral translation and increased dynamic TTTG offset. So he has 4 clinical risk factors. We can see the positive J tracking on him. We've done an MPFL reconstruction on his right side. And you can see here on the left side, in a second, the extent of passive external tibial torsion that he will exhibit. Can we have 1 minute more? Okay. So we'll see the passive external rotation and how far it can go. Which is quite significant for his instability. So in summary, acute lateral patellar dislocation is not a random event, but a mechanical one, secondary to abnormal anatomical factors. Treatment has to be tailored and patient-specific. The narrative that conservative treatment should be the main treatment, as they all do well, should be revisited, and the suggestion that surgical treatment offers similar results to conservative treatment, again, is not true, at least with modern treatment. Each patient has to be assessed individually, clinically, radiologically, with an MRI and CT, and the Warwick anatomical and clinical risk factors model should be used for stratifying risk of recurrence as well as guiding clinicians for treatment. Thank you.